Welcome to the CJD Foundation Virtual Conference. We thank our partners, the Centers for Disease Control and Prevention, and the National Prion Disease Pathology Surveillance Center, and our sponsors, Ionis Pharmaceuticals and Charles River Labs. We're pleased to welcome Dr. Brian Appleby, Director of the National Prion Disease Pathology Surveillance Center, who will provide an update on the activities of the center. Please enter your questions as they occur to you during the presentation. At the conclusion, Dr. Appleby will address as many as time permits, focusing on tonight's topics. For information on other topics such as caregiving, diagnosis, and surveillance, be sure to view the other sessions of this year's virtual conference. We at the CJD Foundation thank the staff of the center for their important work in testing, autopsies, and research in the prion disease field. Now I'm so pleased to introduce Dr. Brian Appleby.
Thank you very much for inviting us to give you an update on the National Prion Disease Pathology Surveillance Center. Again, we are very appreciative to the families, the patients, the CJD Foundation, and the CDC for all of their support, and you'll see that in the presentation today. The center started in 1997 by Dr. Pierluigi Gambetti and CDC. It started at Case Western Reserve University in Ohio, and it was in response largely to variant CJD, which is the kind of CJD due to eating meat contaminated with mad cow disease. So a report was published in 1996, 1997 about some young cases of CJD that had pathology that was different and symptoms that were different to classical CJD, and was later linked to bovine spongiform encephalopathy or mad cow disease. So many countries, including the US at that time, started developing surveillance programs to monitor for an outbreak of further variant CJD in humans due to the mad cow epidemic. That's basically how the US's surveillance center was started as well. We're entirely funded by the Centers for Disease Control and Prevention, and that's largely to help assist them in their surveillance of CJD. So the Prion Center is primarily a neuropathologic surveillance center. What that means is that we collect and we analyze brain tissue of patients who had suspected prion disease. And the reason why that's so important is because pathology, looking at the brain tissue underneath the microscope, is really the only way to definitively diagnose prion disease. As you've heard in earlier talks, we have much better tools to diagnose prion disease while a patient is still living, but the gold standard for a definitive diagnosis remains neuropathology, looking at the brain. It's also the only way that we have to truly determine the type of prion disease. And as a brief review, there are about 4 different etiologies or causes of prion disease: sporadic, by far the most common, followed by genetic, variant CJD due to eating meat contaminated with mad cow disease, and then iatrogenic CJD, which is CJD transmitted through medical procedures. It's the only way to truly know is by looking at the brain tissue. They have different features that we can see underneath the microscope, and the prion protein properties itself are also different. Now, what this allows the CDC to do is determine definitively how common the disease is and to examine patterns, such as, are there increasing numbers overall? Are there clusters of cases? And are there changes in the type of prion disease that are occurring around the country? And fortunately, in our country, we don't have a whole lot of mad cow disease, but unfortunately, we do have an epidemic of prion disease in what we call the cervid species, which is deer, elk, moose, caribou. And that prion disease is called chronic wasting disease. And we don't know whether or not that can be transmitted to humans. We currently don't have any evidence that it is being transmitted, but of course, that's why we have surveillance, to be able to determine if that is happening. And then, as unfortunately what we see with COVID, even though prior strains may not have been transmitted to humans, we don't know that future strains won't become transmissible to humans. So that's why it's vigilant that we continue surveillance, because prion diseases do change, much like viruses and bacteria changes with different strains. Now, a lot of what I reviewed here is also covered in Dr. Ryan Maddox's report from the CDC, and I include a link for that. There is a little bit of crossover in our talks, and that's because we really work hand in hand to achieve the same goals. So I encourage you, if you haven't watched that video, to check it out. I wanted to include this slide because it's something that is often brought up, and of course, because the core of the Prion Center is autopsy, I think it's important for people to understand why patients and families do consider autopsy. It's a very personal choice, and of course, we do respect every patient and family's decision to either do an autopsy or not do an autopsy. But I do think it's important to consider why people decide to do this. And in my experience, I think the greatest benefit is it does help provide a sense of closure to the family. They know for sure what their loved one passed from, and they know for sure what type it is. And although that may not sound like a lot, going through the experience that families have gone through with a loved one with CJD, it does, I think, help very much psychologically to provide some sense of closure to the disease itself. Of course, it's the only way to know for sure whether or not someone had prion disease and the type, and many people want to know whether or not it's genetic. We do genetic analyses on brain tissue, so we are able to tell people whether or not it was a genetic form of prion disease. Many families want to contribute to surveillance, and this is one way to do that, to make sure that their loved one is counted so that we do know how frequent the prion disease is in this country and that we're not missing new epidemics of prion disease. They also want their loved one to be able to contribute to research, and this is a very valuable asset that they can contribute. And of course, by performing the autopsy, it really does contribute to a loved one's legacy of giving back to other people. And you've heard many other talks already this year in the virtual conference of what we've learned about prion disease. And all those discoveries were due to people that donated their brains for research and surveillance. And had those people not done that, we would not know what we know today. So it really does contribute to someone's legacy. Okay, so now I'm going to describe some of the primary activities of the Prion Center. I'm trying to be as inclusive as possible, and sometimes it's difficult because we do a lot of different things. Of course, at the heart of the Prion Center is neuropathologic surveillance, which is funded by CDC. That's always the core, but in order to help improve that, we do a variety of other things. So one thing we do is offer clinical diagnostic tests, because if we can help clinicians achieve a diagnosis of prion disease, then we're much more likely to be able to educate them about the importance of doing an autopsy and neuropathologic surveillance. And in fact, when we do send out results from our clinical diagnostic tests, we use that as an avenue of information to tell clinicians about the autopsy program and the importance of surveillance. That, of course, is part of our outreach and education, but we have a variety of other ways that we try to reach out to a variety of different stakeholders. We provide a variety of consultations that I'll review, and then, of course, we do research. So again, the neuropathologic surveillance, that consists of coordinating autopsies and characterizing the tissue neuropathologically so that we know whether or not it's prion disease and what type it is. The clinical diagnostic tests that we offer in the Prion Center, this is not actually covered by CDC. This is covered by patients' insurance, but it's very important for the CDC goal and mandate of surveillance. We offer 3 spinal fluid tests, 1433 and tau, which are just markers of brain cell injury. So they're not very specific for prion disease itself, but they can be helpful sometimes in diagnosing the case. And then RT-QuIC, which is a disease-specific test that detects the abnormal prion protein itself. That is quite specific for prion disease. It can be quite important for diagnosis. We also offer genetic testing as well on blood. Sometimes this is from family members that know that they had a loved one that passed from genetic prion disease, and they want to know whether or not they carry the mutation. Sometimes it's from someone who is ill with suspected CJD. The family, for whatever reason, knows that they probably won't do an autopsy, but they still want to know whether or not it's genetic. We're able to do that through a blood test. The outreach and education component, we do this through a variety of presentations, publications. We have a website. We also work with key partners on all of these things as well. So, for example, the CJD Foundation has been very helpful in helping us spread the word of the importance of surveillance and also clinical diagnostic tests. And we also help spread the word of the foundation as well. CDC and the Prion Center, as well as the foundation, also work hand in hand to make sure that we're getting good information out to a variety of stakeholders. We do have a variety of consultation services. Many physicians and laboratories do call the Prion Center with a variety of different questions, and we're able to talk to them. We use that opportunity to help educate them about prion disease, but also all of the resources that are available to them in the United States. We do work very closely with state health departments. And as many of you know, we do have an MRI consultation program, which I'll talk about a little bit later, that many of you have also participated in, where we are able to take a CD copy of a patient's brain MRI and give a report as to the likelihood of it to be prion disease. And then we also have a program called the Teleneurology Assessment Program for CJD, or TAP-CJD, that we work in conjunction with a donor as well as the CJD Foundation to help collect longitudinal data on people that often go to autopsy, which is very helpful. But also it allows us to have a better relationship with families, talk them through the illness, and also make sure that they're understanding all the different resources that are available to them. Then, of course, we have research. Much of our research is really focused on characterizing prion disease cases, because when you do surveillance, one of the most important things to do is make sure that you know what's expected. So in order to do that, we have to study each case in detail to make sure that it matches with prior cases, that it's not something new and different. So much of our research focuses on that. It also focuses on diagnostics. We want to help improve clinical diagnostics, but also pathologic diagnostics as well, to make sure that we're able to identify as many prion disease cases as we can, but also determine the type and the cause. And then, as many of you know, and you'll see later, we have a large repository of samples from patients with suspected CJD. That includes brain tissue, but also spinal fluid and blood. And that's very useful for research, not just for the center, but for prion disease researchers around the world. So the Prion Center also becomes a research platform for other researchers to assess those data and tissues for their important research. So I like to include this slide now because I think it's not inherently obvious what we do when we review a case. So when a case goes to autopsy and we receive the brain, we do a variety of things in order to have a comprehensive diagnostic review. We do this for a couple of reasons. Of course, we want the family to get an accurate diagnosis, but we also do it for surveillance purposes as well, to make sure that we know as much about the case as possible and to know whether or not it deviates in any way from what we would expect with known prion diseases. So whether it be through a clinician that works with the center like myself, or through a program like TAP-CJD, where we're able to collect longitudinal clinical history, or on just receiving medical records, we're able to review very important things like age at disease onset, how long the disease was present for, clinical symptoms, as well as known risk factors, such as travel to an area that may have been affected by mad cow disease, or medical procedures that may increase someone's risk of developing CJD. We're able to look at that and categorize that and include it in our database. If the patient also had spinal fluid testing that was conducted at our center, we're able to have those diagnostic tests as well, 1433, tau, and RT-QuIC. RT-QuIC can be really important because RT-QuIC usually is positive in most cases, but there are some types of prion disease where RT-QuIC really isn't that sensitive and it may be negative. So RT-QuIC actually, whether or not it's positive or negative, can be quite helpful actually when we review cases to determine if it matches with everything that we would expect. If the family participated in the brain MRI consultation program, we're able to look at that. And as we'll see later, largely due to research done by Dr. Beasy and largely done by MRI submitted by families to the foundation and other clinicians, we're able to determine whether or not that brain MRI represents a subtype of prion disease. And again, we match that. And then there are a variety of different tests that we do on brain tissue. One of the tests is called a Western blot. And what that does is it looks at the biochemical characteristics of the abnormal prion protein itself. So we all know that the prion protein that causes prion disease is very resistant to what we call proteases or digestion with certain enzymes. So that's what this plus mark is. That means that it was given protease. Now, in most cases, protein should go away because it should be digested. But in the case of prion disease, it remains. These are our controls for a type 1, type 2 prion protein. You can see that the bands have different characteristics, different patterns, different shapes and sizes. And then we can match the patient's case in the frontal cortex, the occipital cortex, and the cerebellum. And we know whether it matches features of type 1 or type 2. We also know the relative amount that occurs in areas of the brain. So this is an example of a patient who had type 2 prion protein that was primarily in the cortex or the outer part of the brain and not in the cerebellum. And that's important to know. And then we do a variety of microscopic examinations that Dr. Cohen does for us. That includes histology using H&E staining, which looks at the structure of the brain. And you can see here, the pink is the brain tissue itself. These yellow whitish areas are actually holes in the brain, which give rise to the original name for prion disease of a spongiform encephalopathy because of the sponge-like appearance. And then we also do immunohistochemistry, where we again treat the brain with protease to digest any proteins. And then we add an antibody that detects the prion protein, and we can stain for that. So these brown deposits are actually abnormal prion proteins that are stained in the brain. Now, there are a variety of different prion protein types, and they're characterized by different spongiform changes in the brain in different areas and deposition of the abnormal prion protein in different areas. And then, of course, we do genetics. And for the genetics, we look at the prion protein gene. We look for the presence or absence of mutations. And then we look at a specific part of the gene called codon 129, where we all have different flavors or polymorphisms that don't cause the disease, but they do have an effect on what the disease looks like. And you can either be methionine, valine, or valine. And that's true for all of us. All of us are one of those three things, but we match that. And then, as you heard about in an earlier talk, for sporadic CJD, we have a molecular subtype where we take that codon 129 polymorphism, MM, MB, or BB. We combine it with the prion protein type by Western blot, type 1 or type 2, and that equals our molecular subtype. So that would be MM1, MB2, VV1, what have you. Those subtypes should have certain characteristics that we see on histology, that we see on brain MRI. They should have clear, sometimes clear diagnostic differences, clear demographic and clinical presentations. These are all the things that we're looking for to make sure that they match. And that gives the final diagnosis of, in one case, sporadic CJD VV2. So if we had all this information on a VV2 case, what it should look like is we'd have type 2 prion protein in the brain. There'd be no mutation. The codon 129 polymorphism would be VV. That VV2 should match the brain tissue underneath the microscope with what we would expect with prior VV2s. The brain MRI should resemble what we would expect with a VV2. The diagnostic tests across the board should usually be positive because they're usually positive in VV2. The age shouldn't be too young. The duration should be pretty typical for CJD at 4 to 6 months. And the clinical presentation is almost always marked by changes in walking and gait, what we call ataxia. and there shouldn't be any known risk factors. So these are all the things that we look for before we say a case is VV2 or something else. So I realize it takes a long time to get the results, and I apologize for that. But part of the reason for that is we want to make sure that we're giving you an accurate diagnosis, that all of these things have been checked appropriately and that makes sense. So we ask for your patience. For those of you that have been patient with us, we're very appreciative. This is what goes into that. And it does take time. As you see, there are a variety of different tests that happen when we do this. So now that we described some of the primary activities of the Prion Center, I want to give you a little bit of an update on what the last year has looked like for us. So most of these data you can find on our website, and I have a little tiny URL posted at the bottom. We update this table about 4 times a year. And what it shows is all the brain referrals that we've gotten, whether it's from neuropathologists or coordinated autopsies. It tells us the total number of referrals by year. So that's how many brains we received each year, how many were found to be prion disease. And as you'll note, usually it's about 60 to 70% are prion disease. And then we determine the type, whether it's sporadic, due to a genetic mutation, due to a medical procedure, or due to eating meat contaminated with mad cow disease. And we have that by year. So you'll see in 2020, we actually had a fair year considering COVID-19, because that really put a damper on our ability to do autopsies. A lot of providers wouldn't do them. A lot of them were delayed, and a lot of them were much more expensive than what they had been in prior years, because we're only able to use certain providers, also because of COVID testing and PPE, a variety of things that were more expensive, suffice it to say. But we still were able to get 358 total referrals last year. So you can see 249 were positive for prion disease. As we would expect, the vast majority of them were sporadic, followed by genetic. And you'll notice that we had 1 case of atherogenic CJD. We also had 1 in 2018. Both of these cases were due to patients receiving human growth hormone from cadavers. And we're talking very long incubation periods. So these patients had received contaminated growth hormone 40 plus years. That's why it's so important to continue to do surveillance and to do it long term, because prion disease incubation periods are very different compared to most infectious diseases, right? Most people know that COVID has an incubation period that's, kind of common for a cold or any other type of infection in days to weeks. But in prion disease, incubation periods are measured in years. So that's why it's important to continue long-term surveillance. You can see that we haven't had a case of variant CJD since 2014. We've had a total of 4 cases in this country, all of which were thought to have been acquired overseas due to prior residential status and travel. So I encourage you, if you're interested in this, to check our website and to look at it occasionally. We update it about 4 times a year. This is a busy slide, so I'll take you through it. Remember before I said that we look at the different types of prion disease. Well, we do this by year because what we're looking for is not just if the number of cases are changing across time, but if the number of types of prion disease are changing by time. So of course, we're looking at brain tissues and cases to see if we see anything new or unusual. But what happens if we have a new prion disease that resembles a prion disease that we already know about? Well, we're not going to know that right away. So we have to track the number of each type of prion disease that we have a category for to make sure that it's not changing over time. So as you'll see, for example, VV2 in 2015, it made up about 15% of cases. And then in 2010, it was about 8% of cases. And then in 2015, it was 12%. And then in 2020, it was 8%. So that's well within a normal fluctuation of what we would expect between 8 and 14% by year. So we do that for each subtype. The other thing that we do is we look at age of onset. So it's very important because we know that one of the things that kind of characterizes new acquired prion diseases is they tend to occur in younger people. So we have the trend we have to track the trend of age of onset. So again, for VV2, we have 68 years of age, 67, 66, 67. It's pretty classic, well within normal fluctuations. Now you compare that to another case of VV1, where we have average age of onset of 53, 63, 61, and then last year 39. So that's of course something that we want to look at, because that's almost half of what we would expect for the average age of onset for VV1. So we of course looked at that, and VV1 is tricky to look at because we don't get very many cases of VV1. They're the rarest type of sporadic CJD. As you can see, each year we had 1 case of VV1, 4 cases of VV1, 4, we had 4 last year. So that's important to know because that really affects your statistical analysis, right? So you can actually have a lot of variation of age of onset and still be within expected limits. So when you actually look at the last 4 cases of VV1 last year, what really brought this mean age of onset down was 1 case that was quite young, but still within what we would expect for VV1, which we know is typically a young onset prion disease. But again, you don't know to look if you're not tracking this over time. So this is one thing that we do. This is one reason why neuropathologic surveillance is so important, because we're able to do this. We're not able to do this on cases that don't go to autopsy. So what I just reviewed is just neuropathologic surveillance. This is not complete surveillance of prion disease. It's just surveillance based on the brain tissue that we receive. A much more comprehensive approach to prion disease surveillance is what the CDC does. And Dr. Maddox reviewed this in his talk. They look at a variety of different things. Of course, they look at death certificates, and then they look at what the Prion Center has done with collecting brains and also with our diagnostic tests. And they match all those things together. So that's a much more comprehensive look at the number of prion disease cases. And I'm not going to talk too much about that because Dr. Maddox did review that in his talk. But I just wanted to point out that that neuropathologic table that you saw doesn't represent complete surveillance of prion disease. One of the things that we've been able to do recently that's very exciting is because RT-QuIC is so specific for prion disease, it's a way that we can actually look at a laboratory-based test for prion disease before they go to autopsy. So what we're able to do, which we weren't able to do before in the laboratory, is look at the number of definitive or definite prion disease cases diagnosed by autopsy, combine it with probable cases of prion disease, which would be defined as those patients who didn't go to autopsy, but they had a positive RT-QuIC result. And that kind of matches with what we would expect from the earlier slide that you saw from Dr. Maddox. And you know, there's some statistical issues with this because we don't know when the RT-QuIC positive cases that didn't go to autopsy passed. So we really don't have a proper accounting for the year, but it's close enough to give you a sense that it matches. So one thing I do want to point out is since we started offering RT-QuIC at the end of 2015, you'll see that the number of RT-QuIC cases have gone up every year, except for last year, where it actually went down to 485. And in fact, what you'll see is that as we offer better diagnostic tests, again, RT-QuIC in 2015, 2016, every year we generally get an increase of about 10 to 15% of samples for spinal fluid. So clinicians are testing more frequently, which is good. About 10% of samples usually are positive by RT-QuIC. But one thing that we've noticed this year is that percentage is actually lower. It's under 10%. And that's because I think people are even testing more this year than what they were before. You'll notice that last year in 2020, we actually had a decreased number of spinal fluids sample submitted. And the reason for that, of course, is COVID. So when we talk about how COVID has affected CJD surveillance, it certainly affected clinical diagnostic testing. I can say that personally because there are certain periods in 2020, I wasn't able to get an MRI or spinal tap or an EEG on patients. And what you can see in this graph is the number of spinal fluid samples we received by month. And, we typically get 500 plus samples a month, but with the shutdown in the majority of the US in April and May, we almost saw half the number of samples that we usually did. And we didn't see a reciprocal increase in cases after that. So I don't know if these patients never got a spinal tap, but that's certainly something that we would be concerned about. And of course, that's going to affect diagnosis of cases, but probably also surveillance as well. It's too early to tell for sure, but that would be a concern. Again, we received blood samples, been pretty steady over the last few years. We usually receive a little under 100 blood samples a year, and these are patients that are symptomatic that aren't going to go to autopsy, and they want to know whether or not they have a mutation, or their family members that want to know whether or not they carry the mutation and are at risk of prion disease. The brain MRI consultation program that many of you participated in, and the CJD Foundation does an excellent job of talking about. We typically get about 90, a little bit less cases every year, and many of them are positive. So last year, 74% of the MRIs that were sent to us were suggestive of prion disease. Many of these cases go to autopsy, and that's really helpful, again, because we have another piece of data to compare with the autopsy to make sure everything fits the way that it should. Brief review, of education and outreach activities. So we have a variety of different faculty backgrounds at our center. We have myself, who's primarily a clinician that sees patients, but we also have a variety of different laboratory scientists. We have Dr. Csid, who has a molecular background, which she has a big interest in genetics. You'll hear a little bit about that later. We have Dr. Noguez, who's a clinical chemist, who has another background. We have Dr. Cohen, a neuropathologist. And we have a variety of different basic science faculty like Dr. Zhao and Kong and Callie. So this enables us to actually have a variety of different outreach opportunities to spread information about prion disease. And that's very helpful as opposed to just having one faculty member with one niche. We participate in as many review articles as we can, chapters that help spread the word. Dr. Cohen and I now do the prion disease articles for Up to Date, which is really important because a lot of clinicians go to Up to Date, which is kind of a website repository when they're diagnosing a case of prion disease or any other disease, and it allows us to talk about resources available to clinicians and families. We have website updates. And then one of the things that we really try to do is, in the past, the reports issued by the Prion Center were very wordy and very difficult, I think, to interpret. So in the last few years, we've tried to make them as simple and straightforward as possible. We've done that with autopsies, and we've done that with spinal fluid. And I think it has helped. There's always going to be an element of education that we have to do, but at least we made the process, I think, a little simpler than what it had been in the past. Foundation is really excellent to help us outreach to a variety of different communities about resources and the importance of surveillance. And of course, we use our consultation activities also as an outreach opportunity. So next, I want to talk about what we do for research at the Prion Center. We talked about a lot of what we do is surveillance-related research. You heard about some of that already, characterizing human prion disease and why that's important for surveillance. And then also we collect these tissues, save them, not just for our research, but for other investigators to request so that they can have access to those valuable tissues for their research. And one of the projects that I've been, again, I think very, very helpful, and that really spans clinical care, neuropathology, surveillance, and research is a lot of the work that Dr. Beasy was able to do through the MRI consultation program. Again, over many years, he's been able to collect many different MRIs. Many of those patients also went to autopsy. And what he was able to do is to develop an algorithm that basically predicts what molecular subtype of sporadic CJD is present based off MRI characteristics. And it is surprisingly quite accurate. And this is important because we use it for surveillance. It's one of those variables that we look at to make sure that everything lines up accordingly. And that's important for us. But I think it also will become important potentially for things like clinical treatment trials, because you have to kind of know what subtype you're treating for randomization and whatnot. So I think largely through the foundation's work, through Dr. Beasley's work and the family's gracious contributions of their MRIs and brain tissues, we've been able to do some pretty important work here. Just to give you an example of what type of research requests we get from other researchers, this is from 2020. We got a total of 839 specimen requests. As you would expect, most of these are brains, but we also get requests for things like CSF, DNA, and other tissues. All of this tissue is shared. It's also shared with data, but the data is anonymized, so it's not able to be linked to any specific person. Okay, so now I just want to end with some future goals of the Prion Center. One of the things we want to do, and we really realize that we need to do a better job with this, and that is we need to do faster clinical testing. There are some things that we can't address. So one of those things is we're the only lab in the country that does the RT-QuIC. And because of that, a lot of labs use reference labs to get us the sample. And what that means is that your local laboratory may send it to another laboratory to send it to us. And that does greatly increase the amount of time that it takes for us to get the specimen. But there are other things that we can do on our side to perhaps make the testing faster. So one way to do that is automate it. So right now, the technicians are manually divvying out all the aliquots to do the testing. And that takes time. So we're investing in doing a machine that will do this for us. That decreases the amount of time to be able to prepare the samples and do the testing, but it also will hopefully allow us to do more runs of RT-QuIC. Unfortunately, RT-QuIC takes 60 hours to do, and that's because of the test itself. So we run RT-QuIC twice a week. If we're able to add even one more run of RT-QuIC in a week, that drastically increases turnaround time. So these are things that we're trying to do to cut down on that as best that we can, at least on our end. We also want to develop an in-house molecular laboratory, so that's genetic testing. And with Dr. Shetty's expertise, she's the lab director here, but also she's going to help spearhead the development of this molecular laboratory so that we can actually do new and fancier things with genetics, not just test the prion protein gene, but be able to test maybe different types of tissues that we weren't able to test before, and to look at things outside of the prion protein gene that we once were not able to look at. So that's exciting. The other thing too is I think most of the directors now at the center have a clinical background. And what we've learned is that having a clinical laboratory infrastructure is really helpful, because clinical laboratory infrastructures are highly efficient. And in the past, when most of the center's work was research or surveillance based, it was less of an issue. But now that we're doing more and more diagnostic clinical testing and demand is greater and greater, we really have to adapt that clinical laboratory infrastructure. And that's going to help our clinical diagnostic testing, but it's also going to help with the surveillance and the research aspects as well. And then, of course, we're going to continue to characterize atypical prion diseases, things that may look a little different, and genetic prion diseases where we don't know that much about. For example, how frequently people with that mutation develop the disease or not, things that we call penetrance. And of course, we're continuing to assist the CDC in their surveillance-related projects, and they have a couple specifically geared towards chronic wasting disease. The other thing that we did this year is the initiation of a tissue request committee. So now, if a researcher requests tissues from us, whereas before it was just me reviewing the request, we now have a panel that is comprised of myself, Dr. Cohen, and Dr. Allison Krause, who is a former CJD Foundation grant recipient. And we look at the project to make sure it makes sense. We look at the justification for the tissue to make sure that that makes sense. And we, either say that it's a justifiable request, or we ask the PI to rethink how they're requesting tissue or the amount to make sure that we're really truly using the tissue the best that we can. So in summary, neuropathologic surveillance of prion disease and related research has been doing quite well, despite COVID-19. We've certainly hit our speed bumps. It's not been without its challenges. God bless our autopsy coordinators who have really bore the brunt of that, as well as our laboratory staff who were essential workers and did come in-house pretty much full-time during COVID-19. So hats off to those individuals. The clinical laboratory, as you've seen from just the number of specimens we receive, has dramatically expanded. And as you see, it's also important for surveillance. We continue to serve as a biorepository for researchers inside the Prion Center, but also outside the Prion Center. And we are truly grateful for all the support from the CDC, healthcare professionals, the foundation, and you, the families, because what we are able to do is not possible without your help and support. And one of those ways that you guys have always helped us is by making sure that Congress keeps us in their budget and that we maintain funding. And undoubtedly, without your support, that would not have happened. So we're very greatly appreciative for that. So unfortunately, we don't meet in person. So usually we bring some of the center staff with us when we come to the foundation. Hopefully we can do that next year, but this is just a little collage of the people that work with us, and I'm truly honored to be able to work with these individuals. They're excellent. They care very much about what they do, and every day I look forward to working with them. So again, thank you so much. And at this time, I think we're going to open it up to questions. Thank you. Good evening. Thank you again for joining us and for listening to our update on the Surveillance Center. And thank you, the families, also for all that you've done for prion disease research, surveillance, and to help other families who are in the same situation. Just a reminder, everything is recorded and will be placed on the CJD Foundation website if you'd like to go back and listen to it. Also, a lot of what I covered briefly and a lot of the questions that we'll touch upon a little bit this evening referred to some specific talks that were previously recorded for this year's virtual conference, and that also is posted on the CJD Foundation website, cjdfoundation.org. There are a couple questions sent to us about COVID and the COVID-19 vaccine possibly being initiators of prion disease. And this is a topic that we've received every single talk this year on the virtual conference, and understandably so with the COVID-19 pandemic. I don't want to spend too much time on it because we have talked about it extensively. So I would refer everyone to the first talk in the conference with Dr. Ryan Maddox and the CDC. In the end, in the question and answer session, we do talk about this in detail about whether or not COVID-19 or the vaccine is associated with CJD. So I'll refer you to that. I empathize with families that keep asking that, because sporadic CJD, I think, is a difficult thing to wrap your head around, because we know that, at least with CJD, it is transmissible. So the thought is that automatically all of them are transmissible. But there are real sporadic cases. That's the majority of cases. And we know that happens in the animal kingdom, and we can replicate that in the laboratory. So for someone to reach out to try to find any potential trigger for CJD, it's completely understandable. And of course, that's what we're trying to do at the Surveillance Center, as well as the CDC, is to make sure that we're not missing other causes of CJD that are preventable. So that leads me to one of the questions. Was someone had lost a loved one who was quite young, in their 50s. And I do know that there have been even younger people. And it can be difficult to reconcile why their loved one passed from this disease. And sometimes it can be fraught with a little bit of guilt. Is there something that shouldn't have been done, something that the patient did or the family did that predisposed them to the illness? And, in the vast majority of cases, the answer to that is no. In most of these cases, 85% are sporadic. Genetic follows with genetic prion diseases. No one does anything wrong. That's just the way genetics are. And then in most transmissible cases, no one knew about the transmissible component of CJD in certain medical procedures back in the day. But because of the long incubation periods, we still see consequences of that. And of course, with variant CJD, part of why the surveillance system exists is to make sure that we don't have cases of mad cow disease in people in this country. And there are specific things that are also done on the agricultural side as well, because we don't want people to get a preventable form of CJD. That's exactly what we don't want. So please, you did not do anything wrong. Your loved one did not do anything wrong. There was another question, and I apologize, I'm going back and forth looking at the questions. One question was about how long it takes to get an autopsy. I did touch on this a little bit. Typically, it takes about 3 months. Now, it takes about 3 months from the time that we get the tissue. Sometimes it varies quite widely in how long it takes for us to get the tissue. And generally, when someone gets a brain-only autopsy, we receive 2 different types of tissue. One is frozen and one is fixed. An fixative that allows us to cut and section and look at the brain underneath the microscope. We don't always receive those tissues at the same time for a variety of reasons. And of course, we don't do all the autopsies in Cleveland. We have providers around the country that our autopsy coordinators work with for the brains to be removed and sent to us. And some of them, actually kind of do it for free or for their own educational component as well. And they may or may not send us the tissue right away. We do follow up on those cases and try to remind them to send it to us as much as possible. But sometimes that is part of the delay, is we just haven't received the tissue from the provider. And we do our best to try to get the tissue as quick as possible. But once we receive the tissue, as you saw on the one slide, where I reviewed how we do a final diagnosis, we're doing a variety of laboratory tests. So we have technicians that do the Western blot, technicians that are staining the brain using H&E and immunohistochemistry. We also do genetics as well. So those are 3 tests that we need to do that are basic in the laboratory, but they take time. And sometimes the tests don't go the way that we would want it to go. So for example, in Western blot, we use a specific antibody to look for the prion protein, and the antibody that we use the first time is very good at capturing the majority of prion proteins. But sometimes it doesn't capture it very well, to where there's a question of what type of prion disease it might be. So we have to use different antibodies or different concentration techniques in order to get an appropriate Western blot for what we're trying to do, and that is to get the families the diagnosis and to do adequate surveillance. And the same can also happen with the histology as well. We may have to, redo the slide so it's at a quality that we feel comfortable with. And then finally, at the end, when we do all the matching that I talked about, which is a lot of different variables that we're matching, sometimes they don't all match up to what we would expect for a specific subtype. So then we have to go back and try to figure out why that might be the case. And sometimes that takes time as well. So I say that in the vast majority of cases, it takes up to 3 months to get the final results. And that final results, of course, includes the genetics, which is what the families usually care the most about. But sometimes if there's any glitch in any of that, or we have to repeat anything, or it takes extra time to do something, it can add substantially to the turnaround time. So if there are questions, please know that you can call the center so that you can at least get an update of kind of where we are. We might not be able to tell you exactly how much longer, because we don't know. We're trying to resolve, something, but we can at least let you know whether or not the report was sent out to the physician and who that physician was that received the report. And I understand it is frustrating, and I really wish we could get a lot of our results out sooner. But again, we have a certain standard we have to reach as well. And we do that for surveillance, but we also do that for you. Another question was, how rare is this disease? This person had a loved one whose mother passed in a fairly small town. And there was another case who passed 20 miles from that individual 3 months prior to their passing. Could there be a correlation? It's an excellent question, and I strongly recommend that You also check out Dr. Ryan Maddox's talk from the CDC, where we do talk a lot about how common the disease is. And my short reply is we kind of use the 1 in a million number, but it's not a good number to use because it's a epidemiologic statistic that we use called incidence. It just means the number of new cases of CJD per year across the entire population. But most people that get CJD are in mid or late life. And sometimes people live longer than a year. So it's not really a great number to use to kind of psychologically get your head around how frequent the illness is. So another way of looking at that is looking at how many deaths occur in the US due to CJD every year. And that number is about 1 in slightly over 6,000 per year. So that's a lifetime risk of lifetime risk of 1 in about 6,200. So again, it's not a common disease, but it's more frequent than certainly that 1 in a million number kind of suggests. And it's a little misleading because it's not the same type of number. But again, it's a fairly uncommon disease, but we would expect to see quote unquote clusters just because when you see rare diseases, all of a sudden, if you have 1 or 2 cases in close proximity to one another, it looks like a cluster. When really, statistically, when you deal with rare and small numbers, it's not. So another example I like to give is I live in a fairly moderate-sized town in northeastern Ohio, and since I've moved here about 10 years ago, I've seen about 5 or 6 cases of CJD within about a 5-mile radius of my house. You know, 1 or 2 of these were genetic and the rest were sporadic. And it matches with what we would expect. And you have to look at other things like ascertainment, do you live in an area where people are maybe a little bit more attuned to prion disease and maybe better at diagnosing it. The other thing that we see, especially in rural areas, is once someone has diagnosed a case of CJD, they are much more likely to diagnose another case of CJD and to do so fairly quickly because it's in their mind, it's on their radar of what to look for. So again, please check out Dr. Maddox's talk because he goes into more detail on that. Another question we had is how easy would it be to detect CJD on an MRI 4 weeks before someone's death or on a spinal tap? And that's an excellent question. It does depend a little bit on the type of prion disease that the person has. But we'll just take, for example, sporadic CJD, because that's 85% of cases. We know from a lot of work that Dr. Beasy did with the MRI study and the work that we do at the center with the spinal fluid is that almost 100% of sporadic CJD cases will be caught by either MRI or by RT-Quick. Now, there's a couple caveats to that, right? So number one is the MRI is reader dependent. So the neuroradiologist has to actually recognize that it is CJD. And that's something that we've struggled with in the community. But, if you have someone who knows what they're looking at with an MRI, it's positive in the majority of cases, 95% of cases. But when you combine MRI with RT-Quick, you capture almost 100% of sporadic CJD. So another question, really good question, is when a spinal tap is done on someone with neurologic issues, is it normal for them to have tests such as 1433, tau, and RT-Quick, which are done at the center? Are these tests that have to be specifically requested? And in fact, the answer to that question is yes. So anytime a doctor orders a test, no matter what that test is, they have to specifically order it or ask for it. So if you do a spinal tap, you actually have to ask for specific tests no matter what, whether it's just looking at the total protein or doing bacterial culture, you have to request that. So pretty much anytime someone gets a spinal tap, they're going to get certain tests done that will be done locally in their hospital's laboratory. And that is things like total protein levels, glucose, and cultures. But there are some tests, excuse me, that are very disease specific and laboratory specific that need to be sent out. And RT-Quick is only done at the Prion Center, so it has to be sent to the Prion Center. 1433, I believe, also is only done at the Prion Center right now. Now, what is nice, and what we try to do to simplify the situation, is if someone has a case of suspected prion disease, they really don't need to know what they're ordering. They just need to send us the spinal fluid, and we will automatically do all 3 tests for them, whether or not they ask for them or not, because it's part of the prion panel. And there are a lot of people that might not know what RT-Quick is, and that's the first time they learn of it. So they sent us a sample for 1433, and they got tau and RT-Quick back, which are better tests for CJD. So there's another question about someone's father passed of CJD last year. They're going through his medical records and found that he was treated with animal hormones, horse growth hormone, and rabbit T cell treatments to boost immunity. We do not know that animal hormones can transmit CJD. We do know that, mad cow disease, presumably through nervous tissue, can do that. And there are some hormones that are nervous system related. That would be a concern. We certainly wouldn't recommend it, but we don't have any evidence that animal hormones do transmit prion disease. We do have evidence that specifically hormones made by glands within the brain that are taken from cadavers can transmit prion disease. So that certainly is a concern. But I would think in your case, your specific question, likely not a concern. Another really great question goes back to when Dr. Gambetti started the Prion Center in 1997. Were we doing sporadic CJD subtypes even back then? I think the year that this person mentions is 2002. So Dr. Gambetti came up with a classification system for sporadic CJD with his colleagues in the late 90s. And so ever since the late 90s, they've been doing this subtyping of sporadic CJD prospectively. But keep in mind, when they came up with their classification system in the late 90s, they needed to use samples from the Prion Center in order to validate their classification system. So we can say that pretty much all cases that were collected through the National Prion Disease Pathology Surveillance Center since its inception has been subtyped via that sporadic CJD classification. And I see we're running short on time, so I'm going to just pick a couple important ones here. If you have questions that I'm not going to get to today, and please reach out to the CJD Foundation, and we can perhaps talk to you offline. There's one question, and this person asked some really good questions. Lisa, I'm going to say her name, not her last name, but Lisa's asked some really good questions. And that is, does a brain biopsy provide sufficient data to classify what type of CJD a person can have? That is an excellent question, because we really do not like brain biopsies for the purpose of diagnosing CJD at the Prion Center. Number one, because a lot of the people that undergo brain biopsies actually don't have prion disease, and you can diagnose prion disease better in a variety of other ways. But also, it puts the patient at risk, and potentially the operating room, physicians and nurses at risk. But the one real reason we really don't like brain biopsies is it's highly dependent on the tissue that we receive. So they usually only take a very small amount of tissue, usually from the frontal cortex, the front part, outside part of the brain. And, they ask us to do analyses on it, but we really don't always know what we're getting. Sometimes we get the brain tissue, sometimes we only get the covering of the brain tissue. The brain is composed of gray and white matter. We need to have gray matter really to do our tests, and we're not guaranteed to get that. So there's a huge issue of whether or not we're getting adequate tissue type and quantity. And then there's the other issue that there are some prion diseases that can actually give you a false negative brain biopsy, because the outside part of the brain may not be severely affected in specific prion disease types. So you would get a negative biopsy but if that patient were to go to autopsy, it would be positive. So, we really don't like brain biopsies from a diagnostic standpoint. Good question, by the way. A couple more. What is the span of the incubation period? So incubation period is the period of time from being exposed to prion disease to developing the illness themselves. And again, this is the case of acquired prion diseases like medically induced transmissions or variant CJD due to mad cow disease. We know from Kuru, which I reviewed a little bit in an earlier talk, that incubation periods can sometimes be 50 plus years. So it can be quite some time. And again, that unfortunately is a characteristic of prion disease, is these long incubation periods. And as you can imagine, that does make investigating acquired forms difficult and makes long-term surveillance absolutely essential in order to capture cases and to investigate potentially new acquired forms of the disease. It's about 8 o'clock now. I think I'm going to stop there. Again, this will be recorded and posted on the CJD Foundation website, cjdfoundation.org. If there are questions that I was not able to get to, I apologize, but please feel free to reach out to the foundation and we can try to get your questions answered. Thank you very much for all that you've done for the Prion Center, for the foundation, for other families. I wish you a good night.